Who will be talking on missed options for lumbar disc degeneration, the way it goes this, and his professional interests include mainly the other spine. He's worked extensively on clinical trials of professional interest in orthopedic trauma and spine surgery. The stock trend is going to teach us more regarding this important and innovative team. So the
for this procedure, we go fireman's scale. So it's like after a lumbar fusion through this fireman's scale approach. So it's not only for the neck registration in our pain, but it's also for leg pain because we got to be the comparison in the group. We are in the surgical on this height. And this group is not like we have reverse Harvard School, which is used for neck surgery. We had those kind of indication, which is DDP, spontaneous damage, medication, and if our patients have no back to us, we use that also now we use once again the rest of the medication is much less, which is around we use a flat surgery, we estimate for approach from the finger, we have not really mind and nothing more. And we are in this two-cycle area, and we go phase 1 and 2. And then we next this first out and things nice on this out. So it's very friendly for the surgeons. You know that the class you can tell you from color that when we it's one of the this is for insurance to have others on the back of their future. So I'm using half the program for absolutely just on the same
that this is used for the numeric calculation of the finger. We take an incision like V-shape also. Whenever it is not possible to cover the digit with the doctor axis flap, then we use the cross finger flap. This is used from the adjacent finger. This is a two-stage thing. So that's why I have told you to use mainly for the solid line of the and now we take it. I learned that from the lab become very popular nowadays. You need Department of Procedure, you need specialized center, you need specialized technique, and you need computer research. Now this small tag in your hand, this one or this one, better to retain them. Normally you are tempted to exercise and try to do same class series. The whole thing has been built up, and the patient does not do more centers at the end of 5 weeks. Same thing, skin grafting has been done. It's a very simple technique, skin grafting. It can give excellent result. This case, normally you go for the what we have done, we have just done is thickness in the when this skin graft is done, the skin graft eventually will contract. Now we are making this thickness skin graft has done the job. The graft is shrunk now and the collateral.
We are sure that the joint line is preserved, restore the normal joint line. As you can see here in this slide, back to the anatomy, the vertical axis of the body axis, mechanical axis, and anatomical axis.
great honor to have one of the most inspiring personalities, one of the dynamic leaders of this country today, Your Highness, you have honored us with your presence. So thank you so very much for being with us. We are equally honored. And to begin with the proceedings, may I request our students to please come and offer a floral bouquet to His Highness Sheikh Rashid bin Humayt Al-Nuaimi. Ladies and gentlemen, it is our honor to have His Highness amongst us, and needless to say that we have to great applause. From India, Mr. P.C. Angul, we thank you, sir, for being with us. May I request our students to kindly welcome him by presenting him with a bouquet. One of the senior most members of the orthopedic and medical fraternity, Your Highness, it's my honor to welcome Dr. Ahmad Kazim, one of the senior most members. May I request our students to welcome Dr. Ahmad Kazim amongst us.
وكذلك جعلناكم أمة وسطا لتكونوا شهداء جعلنا القبلة التي كنت عليها من يتبع.
As I mentioned earlier, we have one of the most inspiring personalities in His Highness Sheikh Rashid bin Humayt Al-Nuaimi, who has been not only a well-wisher and a guiding force for this university, but personally to our own founder president, he has been a well-wisher. Thank you, Your Highness, for being with us, and I seek your permission, sir, to introduce the most eminent personalities from the field of orthopedics and medicine today. And with the permission of this august gathering, it's my proud privilege also in orthopedics, Professor Ahmad Kazim. He is a UAE national who has completed his medicine from Mumbai University in India way back in 1955. This morning, who later went to the UK to pursue his fellowship, and he got his FRCS from Edinburgh and from England, and he was appointed the senior orthopedic surgeon in Trinidad way back in 1962. Later, he was invited to start the Chancellor efforts. The flag of orthopedics was raised to the international standards, apart from the division of the bone using custom-built replacement knee prostheses. In associate retirement in 2004, is to have the joint replacements, particularly for pasted on joint surfaces, which is so simple, so logistic, and a satisfaction to see the elderly aged population re-achieving the pleasures of painless humanoid standing and walking. Inshallah. Pleasure having you, Professor Ahmad Kazim. Ladies and gentlemen, we have Dr. Muhammad Fuad, Director of Medical Orthopedics and Spine Hospital in Dubai, who is also the Chief of Orthopedic Surgery since its opening in 2007. He was the Head of Orthopedics at the Dubai Abu Dhabi. Dr. Vaidli has a BSc, MD and FRCS from Canada, and he has completed US board certification, while Lawande, who completed his post-graduation in orthopedics from Bombay University, Prime Minister's Gold Medal for Surgical Excellence, and also honored as Sarvashri and Samashri titles for the services rendered to the society. Professor Gawande is enlisted in Reference Asia Manual for Men and Women of Achievements in Asia, and he's been practicing in Dubai for the last 13 years. He is a well-known artist for fine arts and abstract paintings, and he is also a recipient of a Diksha in Kriya Yoga. He is an ardent lover of music. Ladies and gentlemen, give it up for Professor V.Y. Gawande, who is a consultant orthopedic surgeon at the Kennedy and Specialist Hospital today. He did his medicine from the University of Isfahan in Iran. He has orthopedics board certification from the same university. He holds an MSc degree on medical education and from National University of Medical Sciences and Health Services, Tehran. He is known as a European expert. He was the Vice Chancellor for Education and Research Affairs at Arak University of Medical Sciences, Iran, apart from being the Director Educational Development Center of WHO Collaborating Center at the National University of Medical Sciences and Health Services in Iran. He was on the editorial board of many journals, published more than 60 papers in international journals. Ladies and gentlemen, please welcome Dr. Medicine from King Saud University Medical College from Riyadh, and he is a specialist fellow in orthopedic sport medicine from McGill University. He is a fellow of the Royal College of Physicians and Surgeons of Canada and has a licentiate from the Medical Council of Canada. He has a very vast teaching experience, a member of multiple hospital. Ladies and gentlemen, Dr. Rashid Al-Shahi from Makkah. Equally important, ladies and gentlemen, Dr. Hisham Al-Khatib. We have orthopedic surgery and trauma surgery and certification in sports medicine, advanced orthopedic surgery and physiotherapy, Austrian medical certification in rheumatology and sports medicine. He also holds PhD in mechanical engineering and biomechanics from the Technical University of Hamburg in Germany. He had this morning, may I request the founder president of Health Medical University to kindly escort His Highness onto the stage to do the honors. This whole conference today, Dr. Amit
whatever fragment that is free there, just to come out. Yeah, so this is the outer pressure. Depends on the skill. It may take maybe half an hour, 40 minutes at most.
Endoscopic surgery, because I see the open operation is for the single side of the system.
Yes, indeed. It is very minimal. We are not dissecting any of the tissue. We are not separating the paravertebral muscles, and that is why. What is the?
But it is charged just when we get back to the work. Over the long term, open versus
Yes, for what we are doing operation, we are operating on the patient to remove the pressure on the root.
Which are the joints that can be scoped? So the most common being the knee and the shoulders, and the other joints which are being scoped. The accessory instruments, the cameras, the singular forceps, simulation can be done through our control. And the hip joint is a very difficult joint to reach through scope, and we need a C-arm along with the radial assistant to reach the joint. The indications are few. It is actually the femoral acetabular impingement, which can be diagnosed and treated by anatomy. This can be done through scope. So very few contraindications are there for transection. Is to restore at least 80 to 90% of the native ACL anatomy. So earlier, all people used to do the single bundle ACL reconstruction, which was a very successful surgery. But in the long term, we have realized that more than 90% of patients in mid-term follow-up develop degenerative changes. So these have full recovery after the single bundle ACL reconstruction. So seeing this model like now. So they were referencing it according to the clock phase reference. That is for the left knee, it used to be the 1 o'clock position, and for the right knee, it should be the 11 o'clock. So this was a 2D structure, whereas knee is a 3D structure. So we used to be non-anatomical in this case. So there was some misgraph which we used to use. So on the scope, you can see the two different insertion sites as seen here and even in the lateral part. So maximally tensed, real bundle is maximally tensed when it is in full extension. So hence it is fixed when the knee is in extension. The female sports persons have more common ACL there. So how it is diagnosed? So when history is important to know how the injury occurred. It can be a direct injury, it can be an indirect injury. So clinically, the patient will, on examination, the patient will have a latent stress positive torn from the tibial side. So why the anatomical double bundle? So these are the words of Freddy Fu of Pittsburgh, and when the hamstrings have been already used, either we have to go for a bone bone graft or go for allografts. The allografts, the results are not so very good because the healing and the revascularization time is long. So when there's the autograft, usually the patient is mobile or back to activity in 3 to 6 months, whereas in allograft it will take more than 1 year. So the revisions are difficult after double bundle reconstruction. Yeah, there are series of revision double bundle, which is not here, but my professor there in Singapore has published a paper on revision ACL, which have been earlier done by bone patella and done later by double bundle, but not done.
In this case, we are replacing two parts. One is PL and the other is PL.
Yeah.
What is the program if one of them fails? This is number one.
Yeah.
Because one of them stabilizes the knee in extension and the other stabilizes the knee in the flexion.
Rotation. Yeah.
And in most of the contacts, both sides will help.
So we have to scope the knee and test for the other bundle. It can be lax. If it is lax, we have to replace both. So if it is not lax, if it is taut enough, then we have to just replace the bundle which has been torn. Okay, second question. Yeah, the quadriceps strength is important. So pre-operatively, as I stressed, it's very important to retain or get back the quadriceps function properly before we go into the surgery. The quadriceps strengthening is important prior to the surgery.
The long-term, I guess it doesn't work or will not fit for us. No, I think on the long run it might be a difference. Still, we don't know exactly what will be the long run for this.
Asian knees, the Japanese and Chinese. But I don't believe we are in the Middle East region. We're not like Chinese in size.
But what we are insisting, what we are seeing in our surgeries, that the whole changes is really different. I think more than one. We're doing the work. We're doing the work.
So what's the way to accept the patient?
Well, there is nothing but
Stuff like that, tried them all, and I'm not going to have surgery. We should be telling these patients, you have to lose weight. We should be telling them operation if they look like the last one. Topical therapies can be broken down into three sort of groups. There's a counter irritant. I think the way these work is they confuse the brain. You get something hot or warm, sends a signal out, and takes away the pain. And there's many different brands. They're basically, they've got camphor in them, or mint, or eucalyptus, and it's inflammatory. And Ketoprofen is a popular one. Ibuprofen comes in a gel. How do you know about Goldman's gel or any gel? These provide local absorption. They tend not to bother the stomach as much as the tablets, and they certainly can be used to provide powers that be. Now, toxin of these drugs is the same. If you use equivalent doses, one is not. Platelets do have all kinds of growth factors, cytokines, things that will fight inflammation, so there's a theory that it may help. There is not much science to this, according to the American College of Rheumatologists and psychosocial interventions. As far as drugs, it works, less than 0.2. Acetaminophen does not work, less than 0.2. NSAIDs does work, 0.29. Topical NSAIDs works even better than oral NSAIDs. Opioids, the highest one of all. If you give narcotics, you get rid of pain. It does work, no surprise there. Intra-articular cortisone, something on the next slide about that. And this one, ASU alpha-hydroxyl and saponifibril, maybe some of you know that, does work. Dietary good studies and compare them to, now, I saw all kinds of things in them, but it's really the glucosamine sulfate that's been proven to work. So the lavage and debridement to do, despite the fact that it happens a lot. Popular operation today is a ceramic on ceramic, usually with